NTA. It's all about you.
NTA language.
Jama'a masu kallon labaran NTA Hausa barkanmu da warhaka. Ni ne
Ekukale lo de yin wa isku de ya.
Igbo murum kachano.
Broadcasted in the language you understand better. Our programs transmitting on the Star Times platform 24 hours.
Àwọn onímọ̀ nípa ètò ẹ̀kọ́ lórílẹ̀-èdè Nàìjíríà.
Hukumar tara kudaden haraji ta ƙasa.
Alanye na ọchịchị mba United Arab Emirates UAE.
The only channel that speaks your language.
Anyị ga-eweta akụkọ gbasara ọrịa ahụ nke wakporo obodo anyị.
Kálejì, mo kọ́kùnrin, mo kóbìnrin, mo kí ọmọdé, mo sì kí àgbàlagbà.
Mu kokari mu sauke nauyin alƙawarin da muka dauka.
Ẹ kú lẹ́yìn tèmi, ẹ káàbọ̀ sórí ètò wa ètò yín ètò obìnrin tó dángájá.
Wa ya fi cancanta a ɗauka a matsayin ɗan aikin cikin gida.
Jama'a
masu kallon tashar NTA Hausa, barkamu da warhaka.
Kí ni ayẹyẹ ọdún iléyá tá máa ń ṣe lọ́dọọdún yìí rọ̀ mọ́?
NTA, you can't beat the rich.
Imagine a station where you access information. Think of a station that creates awareness for national development. Imagine a station that prepares you for a bright and greater future. A station for all ages. Documentaries, classroom and television, events coverage, children's programs and variety shows. Always stay tuned to NTA Knowledge on the Star Times platform, channel 359. For partnership, sponsorship and advert placements, contact us on NTA Knowledge. NTA Knowledge, learning to broaden horizon.
Along a flyway, seasonally, birds migrate often north and south between breeding and wintering grounds. Many species migrate, and these occur naturally on one hand, even though out of necessity, compelled by other environmental factors on the other hand. This migration carries high cost in predation and mortality, including hunting by humans. Migration is driven primarily by availability of food. It occurs mainly in the northern hemisphere, where birds are funneled onto specific routes by natural barriers such as the Mediterranean and Caribbean seas. Migration dates back to about 3,000 years. Every year, on the 9th of May, the United Nations celebrate World's Migratory Birds Day to create awareness and promote safety of birds that migrate. During flight, some birds become incapacitated and are unable to continue the flight, which explains why sometimes we wake up to the sight of rare species of birds in our compounds. What are we supposed to do should this happen? Globally speaking, in other parts of the world, value is attached to this species of bird, even though that cannot be said about most African countries, Nigeria inclusive, where these birds are hunted down either for food or sold in the market to make money.
How to make a sculpture piece.
Hello and welcome. This is NTA Tuesday Live and I'm Cyril Stober. The coming on stream of the National Health Insurance Scheme, particularly the relaunch to cover federal government employees across the country, was applauded in many quarters. This was seen as a right step in meeting the health needs of Nigerians who are constrained by finances to access quality health care and also assist Nigeria attain universal health coverage. More than a decade after, however, stories about the performance of the NHIS are not so pleasant. There are reports of enrollees not getting services for their money, poor healthcare delivery, and alleged compromise or corruption by officials. And this is among other inadequacies. It is believed, widely held, that Nigeria had in 12 years, now despite huge investments annually in the health insurance, recorded a dismal coverage of only about 5% compared to countries like Ghana, Kenya, and Rwanda, which had over 70% coverage with lesser investment. It is believed that corruption is the bane of progress in the NHIS. How true is this? How soon will the scheme be expanded to the informal sector? Are there plans for community-based health insurance? And these are some of the questions we'll be raising tonight on NTA Tuesday Live. But first, let's get to see this report by Chimdima Ndubisi.
The National Health Insurance Scheme was established as a public-private partnership to provide accessible, affordable and quality healthcare services for all Nigerians. But several years down the line, records from the scheme show that only 95% of employees in the formal sector have been covered, with majority of the country's population in the private sector left out. For some of these subscribers, the scheme gives them a breather from out-of-pocket spending whenever they or their relatives are sick.
The service is fine.
You go to the hospital and they will attend to you and you just pay 10% of the cost of the drugs. It's a big relief.
However, due to the operational structure, where health maintenance organizations are the middlemen between the NHIS, enrollees and accredited hospitals, there seem to arise complaints and controversies.
Experience is so bad, which I don't like. Especially if they refer you from one hospital to this place, maybe because of the equipment. So you understand, when you come here, the kind of stress they will be giving you, go there, go here.
My husband will go on he will go on surgery. The doctor was not telling us that the NHIS does not cover the surgery because he had a fracture in his pelvic. I don't understand the meaning of the NHIS since he cannot cover.
In the National Hospital, we're also having some difficulty with HMOs. Some are not paying on time. What is the NHIS paying us back for cesarean operation is far from what we do cesarean operation here.
Another observation is that some hospitals build separate clinics.
For instance, the hospital I enrolled with, they have a special doctor that takes care of NHIS patients as if they are outcasts. Sometimes they will even tell you they don't have medicine for, but if you go to the other one that is not NHIS, you find that you have a medicine.
And most of the time, staff don't even go from year to year, and they're deducting the money. You take your child there, they will say there is no drugs. I want to withdraw because of all this.
Based on these issues, the House of Representatives Committee on Healthcare Services conducted an investigative hearing.
There is sufficient evidence, therefore, to indicate that the scheme is on the threshold of failure, as it is only serving the interests of others.
Allegations against the health maintenance organizations were that some of them are fake, operating with expired licenses, and are diverting funds. But representatives of the health maintenance organizations were in denial. In rising up to its responsibilities, the National Health Insurance Scheme, as the regulator, deployed its officials to hospitals under the scheme for monitoring. A new measure subscribers believe will checkmate activities of the HMOs and hospitals, thereby ensuring quality healthcare service delivery. Chimdima Ndubisi, NTA News.
That report sets the tone for tonight's discussion. Let's start off by introducing our guests. I'd like to welcome to this program the Honorable Mohammed Usman, who's Deputy Chairman of the House of Representatives Committee on Healthcare Services. Thanks for being with us here.
Thank you, sir.
Let me also welcome Professor Usman Yusuf, Executive Secretary of the National Health Insurance Scheme. Thanks for being here.
Thank you for having me, sir.
We're also joined tonight by Dr. Kolawole Owoka, who is Immediate Chairman, Health and Managed Care Association of Nigeria. That's the umbrella body for the HMOs. Thanks for being here.
Thank you, Siri, for having me.
And let's also welcome Dr. Ogunlade Felix, a former executive member of the Nigerian Medical Association, FCT chapter. Thanks for being here.
Thank you for having me.
All right. As usual, we acquaint you with the procedure. We say this every Tuesday. At the appropriate time, you can get to be part of the discussion in the studio. The various platforms will be in your screen. We advise you take advantage of them. However, for those who would be calling in, when your call gets through at the appropriate time, do us a favor, turn down the volume of your TV set. Just reduce the volume. Take it down to a manageable level. That's the way to avoid a hurlback or echo. And the best way to know your call has been passed through is your name will appear on screen. Now, once your name appears on screen, it does mean that the call is through to the studio. And we encourage you to just go ahead with a question or comment. Don't bother about greetings. Just go straight to the point. Ask a question or make a comment. And we encourage you to do that as briefly as possible so that others can also get on the platform. And whatever issues you raise, I guess we'll be willing to address them. So once again, we welcome you to NTA Tuesday Live. Tonight it's the NHIS that we're focusing on. And we'll do it a little bit differently tonight. First, let's get a feel of what the scheme is like. It's been about 12 years now. How effective is it? And has it fulfilled the mandate for which it was set up, and what are the expectations? I'd like to start with the Executive Secretary of the NHIS, Professor Usman Yusuf, to give us a cursory look at the scheme.
Good. So NHIS was created by an act from the House, 1999. It became functional 2005. Its mandate, clear: universal healthcare coverage for all 180 million Nigerians. Number one, protect all these 180 million Nigerians from financial risk when we get ill. Many of us live one paycheck away from poverty. Number four, reduce the cost of healthcare. And number five, provide funding in healthcare. Have we achieved this mandate in the last 12 years? The honest answer coming from me straight is no, we haven't. Let us define what universal healthcare coverage is. It's a very simple but noble concept that every person, regardless of his ability to pay, regardless of whether he's employed or not, regardless of his social status, is entitled to good quality healthcare. And that good quality healthcare is not only a human right, but a tool towards alleviating poverty. We are nowhere near there. I have heard you, Cyril, say 5%. I have news for Nigerians. Ladies and gentlemen, in the last 12 years, we have covered only 1.5% of Nigerians. I'm ashamed to say that, but I don't lie because I don't know how. This is what drives my passion, what boils my blood. Countries that have less than us in terms of human and capital resources have done much better than us. Ghana, Kenya, Rwanda, they've done much better than us. Why? We need to look inwards. They did it without HMOs. So maybe they did something right. And we are not covering our people over the last 12 years. We haven't done well. What I've done when I came in is I came from academia, so I asked the tough questions. Why are we where we are? How much money has come in? How much money has gone out? To whom? For what? You want me to continue or allow others to?
Well, you've just situated it, and it's not a very palatable picture we're seeing here, but okay. I suppose you even posed the question already. So let's come back to the Deputy Chairman of the House of Representatives Committee on Healthcare Services. We just heard what the law says, why this body was set up. What have you seen?
Well, thank you very much once more for this opportunity to come and shed light, on this important subject. Let me say that as far back as a year ago, the House of Rep, the Nigerian Parliament, and as representatives of Nigerian people, representing various constituencies of Nigeria, we received a lot of petitions, from various quarters, really. These petitions, were on the non-functionality of the NHIS, scheme. And Nigerians were expressing, lots of, concern that the scheme was not really working. And as the NHIS husband, said, that people were not really covered. Enrollees were suffering, in the hospitals, because enrollees will go and sometimes they're set back, and they're not attended, to. And, this kept, coming in. So the chairman of the committee now summoned a meeting of the committee members to really have a look at it, to say, look, what do we do? This is really happening. So we decided really to set out a sort of like underground agents to really visit, some of these hospitals across, the nation. Some went to as far as Lagos, Port Harcourt, Bauchi, to really pose as patients, in the hospital, so that we get to understand whether, those petitions, because usually we don't act like that. We need to really confirm, those really. And we realized that there's certain elements, of truth in the petitions. So based on that, the chairman of the committee, which Kiakapo, presented, a motion, on the floor, of the House. Sometimes last year in November, educating, other legislatures that this was really the situation. And with certain prayers that considering the allegations, because in the petition there are weighty allegations, diversion of funds, because over 351 billion naira has so far been, expended in the last 12 years, in this, that some of the petitions show that the money does not really get, in fact, the service providers. They've been diverted, and all sorts of things, really. So this was presented in the House, and there was a resolution which was approved that, look, even the payment, being met, to the HMOs, should be stopped pending investigation, really, because this is taxpayers' money. This is Nigeria's money, really, as well as allow the Committee on Healthcare Service, to provide, to do a sort of, thorough investigation of the activities of not only the HMOs, but the service providers over the last 8 years, and then the situation of the enrollees, and then report back, to the House. And it was based on that, resolution of the House that the House decided, to conduct a two-day public, hearing when all the stakeholders, were really invited to come and make, the submissions, and oral submissions were made, written submissions, were made, and that was really what was done almost about a couple of weeks ago. So that's what I want to say by way of introduction to the topic.
All right. So far, tough. But let's come to Dr. Kolawole Owoka, who's the immediate chair of the HMOs.
Yeah, thank you. Let me be very brief so that I will go to the point. The health insurance did not start in 1999. Dr. Moses Majekodunmi, may he rest in peace, wrote a book, My Lord, What a Morning. And he put up his experience as the first Minister of Health. He's been, since 1962, trying to make sure that health insurance comes in, because he knows that that is the only way out. That is the only way out by which you can get a predictable health, and one that the whole world is the global trend. So if we want to join developed country with good health statistics, we don't have a choice than to follow health insurance. And that is why so many people continued until we got that act. Now, when that act came, it was made a public-private partnership. And it was done such that it will go around the whole country. But unfortunately, President Obasanjo had problem with the labor. They said they were not ready. Then President Obasanjo was convinced that he has seen other countries doing it, so he is going to go forward. So he went forward, paid the premium only for federal civil servants. So please, there is a lot of misinformation to Nigerians. That money is not for the whole country. In insurance, the basic law of insurance is no premium, no cover. If you want to cover informal sector, you have to arrange them, pull them together, and see how to get their premium. If you want to cover organized private sector, pay for them, tell them the premium, and see what they have. The only premium that is stored in the NHIS are only civil servants of the Federal Republic of Nigeria, not even states. So President Obasanjo expected that immediately it started, other states should follow, local governments should follow, organizations should follow, and then the informal sector will follow. But now, if you are to judge us, we have covered 99% of every federal civil servant. That is what you should use to judge us. If you now want to say, okay, that money can help sometimes if we start getting the premium of all the other groups. So that means we have to call the state government and say, look, what do you have for your workers? Then we have to call the local government. Then we have to go to the organizations and do it. And we have to go to the informal sector. Go then by association, cooperative by cooperative, get what they have. And it is then the meaningful one that the government started with can help to cross-subsidize. But for anybody to sit down and say it is that money that will go to 180 million, it means the basis of it, they are not following the basis of health insurance. In insurance, you pay a small amount of money called premium. And that premium allows you to dip your hand into the pool when you are sick, so that you come only with your card, you don't need to pay again. But people's premium is only for the civil servants paid by President Obasanjo. That's the only one. It is not for the whole country. Please, it's a misinformation I want to seize the opportunity to correct seriously. We have done well by covering 99%. If there are problems, let's sit down together and iron out where are those problems.
All right.
Please.
And that's what we'll do, because even as you say with the federal civil servants, there are a whole load of problems and complaints.
Those are things that we can iron out.
And this, of course, we'll get to. But let's come to Dr. Gunladi Felix.
Yes, thank you, moderator. The NHIS scheme is a very laudable scheme. That since the inception of the scheme, Nigeria have taken the giant step to join the Community of Nations. And unfortunately, according to the last speaker, the scheme was focusing only the federal civil servant. And we expected, we in the private hospital practice, we expected that the scheme is going to link the hospital in the standard way it's supposed to be. Because most of the problem is the division within the health practice in the country. We expected the scheme to link the private, the government, and the others health practitioners together. But unfortunately, the scheme went on to divide it into you are the private, you are the government, you are the pharmacists, you are the nurses. So some health practitioners started getting worried that, oh, it's just to give money to the doctors. But basically, the scheme has actually helped. But the main problem we have is how to manage the scheme, how to educate the enrollees, and how to expand the scheme to the non-formal sector, which is about 90% of the population. And in the private setting, we expect the scheme to actually focus on division in healthcare, primary healthcare, secondary healthcare, and tertiary healthcare. That is where the enrollees have a problem. That's where the HMO are having a problem. That's where the private organizations are having a problem, because it is very difficult for anybody to understand what are you going to do. They thought you can just go to the healthcare provider and get everything. And trust Nigerians. They even thought it's their money. They must go and spend it. Until we were well educated and the scheme is well expanded, so that we have enough space to manage the form and to get to the country like UK, where it's not the NHS that manage direct. It is organization like BUPA, a private organization that run the scheme. And they are going to level of even having drugs production for the NHS program, so that nobody will doubt. And they will see the seriousness of the program, of the government, and everybody well informed on what are you going to get. I believe if all these problems are highlighted and well managed, it's a very good program for the Nigeria.
All right, I suppose the question might be raised to say, if, as you say, this is only the federal civil servants whose premium was paid, even with that, the scheme is still fraught with serious challenges and problems. Then what are we looking at when we extend it? So let me come to Honorable Mohammed Usman here. I suppose that among the petitions you received were those of civil servants.
Yeah, like you said rightly, even among the civil servants, you know, they're not really happy, because most of the enrollees, in fact, some that we have interviewed, some that have really written, you know, to us. And I still remember also, you know, the submission of the NLC president, you know. I hope within the next couple of minutes he'll be able, you know, to join us in this discussion. He said it very clear, you know, that his members are really suffering and are not really enjoying, you know, the benefits of this scheme, because many a times, you know, based on also, you know, the petitions, you know, the HMOs will collect, you know, money, and they don't really remit, you know, they don't really pay, you know, the capitation fee to the service providers, to the hospital. And that's why so many a times, you know, the enrollees are turned back. They're not attended, you see, too, really. And sometimes they find it difficult, you know, when they try, in fact, even to get in touch, you know, with the HMOs, in terms of, you know, placing, you know, a call to say, look, so patient, or rather, I'm in the hospital, and the hospital is refusing, you know, to attend you to me, come to my rescue. So there are, you know, so it means, you see, even if we are to go, you know, by what he said, you know, civil servants are not really enjoying, because of the fact that the right things are not really done. In fact, civil servants have been shortchanged.
All right, Executive Secretary, there are two issues here. One has to do with the scope of the coverage, the services covered under the NHIS scheme. What's the scope? What is covered? Because that also, we've heard, is a challenge. And you've probably heard of the allegations against the HMOs as well. Let's start from that.
Good. So when I came, just did situation analysis. Why are we where we are? I'm the first chief executive of the NHIS to say the problem starts with the NHIS. We have not been the regulator we need to be. What we have done, we have relinquished our responsibility given to us by an act of law, handed that over to HMOs. What are these responsibilities? We've handed over enrollment to them. We've handed over people's money to them, no questions asked. We have handed over to them the power to decide when a patient goes from hospital A to hospital B. We have even handed over the regulation to them. This afternoon, today, a mother called me, the mother of a 13-year-old patient who has sickle cell disease. She went to Garki Hospital yesterday at 1 p.m. She needed to be admitted, needed to call an HMO. Called, nobody picked. Came in the morning, I heard the story. I drove, Garki Hospital did the right thing. Admitted the patient regardless of whether they were going to be paid or not. I drove to that hospital, saw the patient. I am a pediatric hematologist oncologist. I know the pain sickle cell patients go to, and I'm a parent too. I went, I saw this patient, I saw this parent, and I drove directly to the office of the HMO. HMO, I pay you 10 million naira every month as admin fee, which is nothing but commission. Give me one good reason why you've not been picking phone calls from patients. You have to humanize these organizations you call HMO or NHIS. First, we're here to serve. So this is what boils me. NHIS, we've not been the good regulators we need to be. We are not good regulators, so we allow HMOs to do what they want. Secondly, HMOs, they are our next stakeholders. What have they done over the years? I have seen money I give them. Every HMO over the last 12 years, I have record of how much we pay. To every HMO, we pay them 3 forms of payment. Before I came, it used to be 3 months ahead. The first payment is admin fee, which is nothing, ladies and gentlemen, but commission. The second is capitation. They are supposed to be a conduit. We pay direct, they are supposed to pay directly to hospitals. The third is fee for service. If a patient goes to hospital and he gets billed and they bill HMOs, HMOs supposed to pay. There's another payment they are supposed to make to the NHIS, which is for every private patient they accrue, they need to pay the NHIS. Let's go back to the admin fee. That is money that goes into their pockets, no questions asked. Capitation. They are supposed to pay that whole to hospitals. They have not been paying. I have the record. Patients go to hospitals, they get treated not with the respect and dignity they deserve because HMOs have not been paying. What do they do with the money? One of 3 things. Number one, they either fix it, I have access to their account, or they buy foreign exchange, or they get loan and use that as collateral. You have consistently hundreds of millions coming to you every quarter, and you don't pay hospitals. They issue dead checks to hospitals. Patients don't get treated well. Essentially, NHIS, what we have done over the last 12 years, we've been milking this cow, handing over the milk to HMOs, and they give crumbs to doctors. Where is the enrollee? Enrollee is left holding the horns of the cow. And hospitals have not done as well. They do not treat our patients well. They overcharge our patients. They do not treat them with the respect they deserve. I address all CMDs, 56 of them. 6, 7 of them were my former students. All of them are my friends. I told them, I'm in the midst of friends. I can take liberty to tell you guys the truth. And the truth is, this is not the oath we took as doctors. We are not treating our patients well. Consistently, what I hear, HMOs are not paying us. And I will get that money back from HMOs and pay hospitals. Take that excuse off the table so I concentrate on hospitals.
Okay. The phone lines are already open, and our first caller tonight is calling in from Abuja here. Shuaibu is on the line from Abuja. Hello, Shuaibu. Go ahead.
Hello, good evening.
Good evening.
The matter we are seeing, they are discussing on the NHIS in Nigeria and for the past 12 years and what they have been doing. But very sincerely, I am very, very happy with the Prof, the Executive Secretary, with the way he started his preamble, and the other speakers too. But if we are to be very sincere to ourselves and to Nigerians, actually, they have not really been doing very well, because the excuses and complaints from people, from different hospitals is enough to show that really, Nigerians are not getting what we are supposed to get from NHIS. You go to hospital, you are covered under the NHIS, you'll be told there is no drug, and which is very, very unfortunate. And just like as Prof said, government is paying this money to the HMO. But what is the problem? Why the HMO cannot do their own duty to make sure that what they're supposed to do, by taking care of the patient, is being done without any question? Because government is paying. Of course, there is a speaker there, which I can't remember his name. He mentioned that NHIS only covers the federal government, civil servants. Fine. In as much as we want the NHIS to cover the whole Nigeria, irrespective of where they come from, whether they are civil servants or not. But we know that is another discussion of another day. But the federal civil servants that the NHIS covers, are the federal civil servants actually been benefiting, 100% from this very scheme in 2012? The answer is no, because there are many people who go to the hospital today and they will not get the service they need. Well, in as much as we will not condemn the whole scheme. Yes, of course, it is a federal government scheme. They are trying. It's even good as we have started it. We know definitely we have to start somewhere, and they have started. But sincerely, federal government needs to stand very well with the regulator, which is the NHIS, to make sure that all the money being paid to HMO, there should be somebody that will follow them to the latter, that they use this money, so that this money will not get into their pocket. Why people will be suffering go to the hospital without drugs? It is very unfortunate. But we pray that something, drastic, should be taken, so that at least we will not continue this way. Thank you.
Thank you very much, Shuaibu. Well, let's come to Dr. Kolawole Owoka.
Thank you.
Even in the background report we had at the start of this program, you heard some people who were interviewed say, first, the way they're treated in hospitals when they go there, it's as if, they belong to another species of human beings. Once they just ask you, are you paying or are you under NHIS? And once you say NHIS,
they ask you to wait aside.
The segregation begins at that point.
Yeah.
The hospitals say, well, the HMOs have not been responding to them the way they should.
Good.
What is the problem with the HMOs?
Thank you. Honestly, Siri, there's no problem with the HMO. If the scheme has been so put that there is an operator. Just imagine like the central bank. The central bank is there. All the commercial banks are the operators. So if you think any commercial bank does anything, the central bank is there watching and can discipline them. There was a time they believed that the banking sector had problems. Soludo came in. He did not come out to start lumping everybody together. There were 86. He laid down the plans, and before we know it, there were 25 left. Those who couldn't get on board had to march. So when we saw a new ES, we were very happy. Say, yes, let us sit down one-on-one and see how to move forward. Because in all honesty, this is a teething. When a new thing starts, there will be a lot of teething problems. And we have to engage our regulator so as to know how to start and where things are wrong so that we can correct them. For example, we want a regulator who is very strict and who can even use a hammer. I've said that when I was chairman, before I handed over in December, that look, when we started, we were only 8 HMOs. We were only 8, and at that time, I can give you all the names of the 8. As the ES just mentioned that he called somebody, even if you don't get that HMO, any of us will do the job because we were all so close and we know each other. But gradually, from 2005, we were shocked when it became 28, from there 38, from there 48. Now we are 69, so I don't even know the number.
You're saying the number is unwieldy?
I believe so, because the NHIS started, we faced Augusto & Co., a rating agency, before in fact, there are about 4,000 HMOs that put up for for accreditation, and only 8 of us were picked.
All right, we'll return
when
to you
we
in just a
started.
moment. We have on the line from Lagos, Austin. Austin, hello, go ahead.
Yeah. Hello?
Hello, Austin, go ahead.
Yeah, I want to contribute on this HMO. Yeah, I want to contribute on this issue of this HMO thing.
Go ahead. You want to contribute? Go right ahead.
Yes. I have colleagues who are once a victim of this HMO of a thing. And I have a colleague, he sustained an injury. So he went to a hospital So they now told him to, now asked him to call the HMO. So he went and he called the HMO. So after the whole thing, the guy got frustrated and decided to go and treat himself in another place. So I want the government to please kindly look into this issue of this HMO. I think there's something fishy going on around this HMO. If the government should look into this matter kindly, please. That's my contribution.
All right, thank you very much, Austin. Well, Dr. Walker, you had Austin as well. As he puts it, there's something fishy.
There's nothing fishy. The regulator should be able to know those doing well and those not doing well.
You were chair of
and
the
not
HMOs.
only that, every penny you pay any HMO, we have what is called advance payment guarantee bond that guarantees that money. So the money is not lost. The money can be collected.
Okay.
And then if you pay an HMO this month and you believe he doesn't pay next month, why should you pay him the 3rd month?
Okay, let me put this
that is
question
still
to you,
regulatory
Dr. Walker.
action.
You were chair of the Association of HMOs.
Yeah.
Was it that you never heard complaints about HMOs?
We reported some of us, and some of them are delisted. We reported some, they were delisted. Some were suspended. As the years, you must have met that some were removed and some were suspended. Because we made reports.
Okay, so what we're hearing is real. It's not as if these are phantom, stories which have been...
Well, there are some misinformation added to it. The HMOs doing their work, come to their call center, you'll be amazed what work is going on. I have about 8 people receiving calls all over the country. Any day, you don't need to give me information. Come and see what is happening. Come to our call center. Come to our quality assurance center. You will see doctors and nurses going from one place to the other, attending to people. You will be shocked.
All right.
But when there are people not doing their job, that's why the regulator is there. That's why it's a scheme. You have somebody who is a regulator. You can regulate the HMO. You can regulate the providers. It's there. And he has a hammer. He can stop them. He may not pay them. He can remove them. He can reaccredit them. He has all the powers.
All right. Let's go back to the phones now. We have Akin calling in from Abuja. Hello, Akin. Go ahead.
Hello, Cyril. How are you?
Good evening.
Good evening. Let me just quickly contribute. I want to commend the ES. The short statement he made there shows that he knows what he is doing and is ready to get the job done. I also want him to look into what the former chairman is saying about the unwieldy number of HMO. Maybe that should be looked into. Maybe there's if there were fewer, maybe they will be able to regulate them better. That's just my contribution.
All right. Thank you very much, Akin. Okay. Perhaps, yes.
Right. I have been privileged to practice in Nigeria, the UK, and the United States, where HMOs came from. And I've said it. If you do not know how to paste, do not copy. We copy the United States system and brought it here to the advantage of HMOs, disadvantaging the little guy. I have seen it. This is what happens in Nigeria. Central bank, let me give you an example. Central bank gives money to banks and banks give money to people, correct? And central bank regulate banks. NNPC gives petrol to petrol station and petrol station give to people, and NNPC regulate those. NHIS, over the last 12 years, we give money to HMOs. We give them patients. There is nobody in any ministry that has the right to choose his HMO. I am the chief executive of NHIS. I have been handed over to Hygeia. They'll come and ask me, what's your bank, Zenith? What's your distance? Nobody asks me what is my HMO. It's been rigged. Everybody is handed over to HMO. Tell me, what do HMOs do? I can pay money directly to hospitals and save that commission. With that commission, I'll cover more Nigerians. Because I have seen how much commission I pay them in 12 years. That is enough for me to cover millions of Nigerians. And I have seen how many they have brought. If our goal is universal healthcare coverage, that's bringing more people outside this, how many have HMOs brought into the pool? In 12 years, they have brought 450,000. They gave me that number themselves. So for every patient they brought in, NHIS gives them 10 million commission. The problem, Nigerians, we do not need HMOs. HMOs in the social setting, they can go and accrue patients and bring them into the pool, and NHIS will be the regulator. But they are feeding where they have not sown. And they have fed really fast. Fellow Nigerians, they have not provided the service they need to provide. There's so much out that has come in. I can do much better with that money by covering more Nigerians.
Okay. Back to the phones. From Benin, we have another caller, Iweka, who's calling in from Benin. Hello, Iweka.
I was a federal staff, and I registered for NHIS at the beginning. And I want to say that before this program came into existence, I know that we were doing the federal staff in medical allowance. Since this program came in, we registered. I've just retired now after serving in government. I never benefited from that NHIS system. And no medical allowance was paid. Even to today, my ID card was not given to me. When you go to their office in Nigeria, they give you a lot of stories and so many other things. Even some of the hospitals, they still register. Some of them say they no longer render such services. So it's because a thing that one continue to wonder how things work in Nigeria. And at the end, civil servants that suffer this whole thing. So if this discussion will be able to solve the problem of NHIS, it will be very important.
All right.
Hello?
Yes, we're with you.
Hello?
Yes, we're with you. Go ahead.
So that is my position. That is my position.
All right.
The problem should be civil servants are suffering. Many civil servants will register. They are not enjoying it.
Okay. All right, Iweka. Thank you very much. Well, let's come to Dr. Felix. Doctors turn away, hospitals turn away patients, and even the hospitals themselves, first, on one leg, they allege the HMOs are not paying them. On another footing, hospitals also have been accused of, treating patients with levity and, as long as it's on the NHI scheme.
Yes, thank you. The healthcare provider, which group I belong, I think in the last 12 years, we are really been coping. Whether I mean coping, we are really coping well, because the scheme is supposed to be a universal coverage, and the scheme is supposed to be social health insurance, and the scheme expected us to treat everybody equally. So it's a big problem on our neck, in the sense that you are a private hospital now, you pay your rent, you pay your staff, you pay for your drugs. And the scheme expects you to give to Mr. A and Mr. B on the same social health insurance. And what they inform us, HMO, is it's a game of number. The more you get, the more you have reserve. But unfortunately for us, the economy has caused a serious problem on our neck. If you have 100 enrollees, before you have a reserve, maybe 20 comes to the hospital. But now, 110 of them want to use the insurance. Who do have any reserve?
So that's what insurance is all about, isn't that?
Exactly. Then, secondly, the problem we have again is the drug. Because of importation of drug.
Because I suppose in the past that you painted, where you have 100 enrollees and maybe only 20 come, to whose advantage was that?
That is
exactly. So if you had had the good times, what's wrong with facing the sour times?
That is what I say. We are going through it all. Now, the hospital have double insult, especially the private setting. You cannot meet up the drug supply because of the high cost of importation and serious delay for payment of the premium. So those are the basic problems we are suffering.
Okay.
Despite that, the services we are rendering can still be compared to standard.
All right. Okay, we'll come back to you in a moment, but let's take this call coming from Kano. Nura is calling in from Kano. Hello.
Hello. Hello, good evening. How are you?
Yes, go ahead. Good evening.
Yes, I'm very happy to have an opportunity to contribute in this special gathering, because this is the kind of gathering we people have been wanting to actually happen. Because this means that we are going somewhere, because this NHIS issue is always in the throat of every Nigerian, because the issue is actually what the ES have been saying. It's not supposed to be here where it is now. It's supposed to be very far away from where it is now. And this is not an issue of everybody defending himself, like what the HMO guy, is saying, because this is supposed to be something that people are just accepting corrections from the Nigerians, because the NHIS issue, actually, as I'm saying it, is the issue of the HMOs. They are the ones that are not actually doing what they are supposed to do. But I appreciate all, but I urge all the HMOs and the people that are within the NHIS and the stakeholders to actually work on the NHIS, because all the Nigerians, I'm speaking on behalf of them, are suffering from this NHIS issue. Thank you very much for giving me the opportunity.
All right. Thank you very much, Nura. So let's return to Dr. Felix. Again, you also raised the issue of payment. They say, you had to cope because payment is not being made.
Yes.
You were an executive member of the NMA.
Yes.
It's possible that you also would have heard issues where people had complained about what some health providers were doing. You got reports about that.
Yes.
And you took a look, hopefully, into those issues. Did you find that in some cases, the health providers were turning back patients, not just because of non-payment, but for other issues? And sometimes people are told easily, drugs not available.
Yeah, the main issue in the healthcare provider section is, one, according to what your secretary said, we have serious problem with some of the HMOs. And then, as a private practitioner, the first is a practice, or the second, you must make again.
All right. So there's also the element of profit.
There's no way your money is being tied down for 6 months without making a loss. And then the main problem area is the secondary care. Some of the primary care, people can come to us with basic treatment, go home. But we always have problem when you get to secondary care. And to link the HMO and the secondary care center is always a problem. And that's what most of the patients call, they didn't treat us well. But at our own level, there's no way we can guide except HMO move fast. Then most of the people at the secondary care, they don't recognize the payments from NHIS. That's very important. Somebody's having high problem. Your hospital provide primary care, simple antibiotics, simple eyeglasses. But when it comes to high operation, most of the centers that will do operation, they say they cannot collect the tariff they are giving them.
So it will be difficult for us to get to the next level. At HMO, we advise you to refer, but to where? At the end of the day, we're going to suffer.
That's it. The question is where. Let's go back to the phones. We have calling in from Niger, Adedukun. Hello, Adedukun, go ahead.
Hello, good evening.
Good evening.
Let me first of all appreciate the Executive Secretary of NHIS for taking a bold step as far as this NHIS program is concerned. I think the best thing that can happen to Nigeria is this scheme. But unfortunately, those people that have been the headship of National Health Insurance Scheme have not as bold and really proposed like the present Executive Secretary we have now. The issue is beyond an individual. It's an institute that we need to sanitize. By the time we are putting blame on HMO or facilities, that is not the issue. If the head of the family is not bold enough to call his children into order, there's going to be problems. My prayer is that by the time this man steps out of that NHIS, what's going to happen? So we need to really do a critical analysis of what does this thing meant to be, and who are the people responsible. As far as I'm concerned, HMO, healthcare provider cannot do beyond whatever NHIS asks them to do. If you ask some rules and regulations and any of them go against it, there will be sanctions. But today, we have a very, very active and someone that wants to really get the place sanitized. Tomorrow, what happens? This is a typical system in Nigeria. People that head an institution should look at it and make sure that they are the ones that sanitize the place. People like HMO is like your employees. The health facility is like that. If you yourself can really put them and say, this is what I want, something we are discussing about, it won't take place. As far as I'm concerned, HMO does not have problem. Healthcare facility provider does not have problem. National Health Insurance Scheme is the main issue that we need to really sanitize and make sure that the right people are doing their work. The secretary cannot be everywhere. You have some lieutenants. Are they doing their job? That is there before you got to that place. Now that you got there, you discover a lot of things that are not doing rightly. As far as I'm concerned, the system we met here gives room for HMO, for healthcare facility to practice platforms. And I must tell you that not all HMO are bad. Not all healthcare facilities are also good. But the point is that is the job what really doing their job. Until we get things done properly in this country, that's why things can be okay. As far as I'm concerned, I think the National Health Insurance Scheme should do make sure that they really do a surgical analysis of the system. Thank you.
All right, thank you very much, Adeduku. Well, let me just put this quickly to the Deputy Chair of the House Committee on Health. Is it that somewhere along the line, while this act was being put in place, is it that we missed something out, or, you know, because of the act there are loopholes which can be exploited? Have we taken a look at the act?
Well, as far as I'm concerned, no act is very perfect, 100%. And it can always be improved upon. But you see, the whole question is the implementation, really. And as far as I'm concerned, you know, there are faults, you see, in, among all the critical stakeholders, even the NHIS, you see, itself really, yeah, it can be improved, you know, upon. And when the new ES, you know, came on board, really, he started, you know, trying, you know, to revolutionize, you know, the place, to make the people really work, to bring in, you know, a lot of, you know, reforms, you know, changes. There was a former, you know, management. That was never done, and based on my understanding, I think then there was this heavy, you know, collaboration, you know, between some of the staff as well as the HMOs in defrauding, you know, Nigerians. So many a times I feel our problem sometimes is not the law, but is the implementation, you know, as defective as the law, you know, the act, you see, could be, if well implemented by everybody, really, everything's really going to work, you see, very well. Like the healthcare, you see, providers, part of, you see, the problem is that they never receive, you know, the payment. There was never, you know, a time when the NHIS, refused, fulfilling its own obligation of release of funds, really, particularly, capitation and the other two. But the money, will never be released, to the healthcare, providers. So that way, this is a default, by the, HMOs. And at the end of the day, who suffers? The healthcare provider, suffers. And the enrollees, who are supposed to be the major beneficiary, do not really benefit because some people, some actors refuse, to perform their job, in accordance with the law.
Okay. All right. We take another call now from Kaduna this time. Namama calling in from Kaduna. Hello.
Please, good evening.
Good evening.
Please, I want to commend the Executive Secretary of NHIS. My contribution goes this way. Why not make the hospital access the funds direct from the NHIS? Since they are having problem with HMOs. Thank you.
Okay, thank you very much. Straightforward question, and we'll be posing that question, and we'll ask the Executive Secretary to respond to that in a short while from now. But for the meantime, we'll take a short break. When we come back, we'll keep that question in view, and we'll ask the Executive Secretary to respond to this suggestion from Namama that why not give the money direct to the healthcare providers if they're having challenges with the HMOs. We will also turn the searchlight on the NHIS itself and say, look, as a regulator, what are the things that have gone wrong with the NHIS itself? Why has it been unable to sanction those who have fallen foul of the Act? But that will be after this timeout. Stay with us on NTA Tuesday Live. We'll be back.
Nigerians, our fearless officers and men of the Nigerian military are winning the war against Boko Haram. Today, all occupied territories have been recovered and Boko Haram has been degraded. Our affected brothers and sisters are getting their lives back. However, they are now after you and me. In our mosques, churches, schools, motor parks, markets, entertainment centers, and public gatherings. Be vigilant. Be security conscious. Report suspicious persons, objects, and movements to the police and other security agencies. The security of our nation is a duty for you and me. Nigeria, unite against terrorism.
This message is brought to you by the Federal Ministry of Information and Culture.
The struggle for independence had been a long and tough one. Our founding fathers and compatriots sacrificed their comfort and even shed their blood. We cannot at this point in history afford to spirit away their sacrifices for immediate but temporary gains of today. Let us emphasize what unites and not what divides us. Working for the unity of purpose with a stronger vision for a better tomorrow. NTA, growing with the nation.
Nigeria, the only country we can train with remarkable potentials to excel. Let us believe in ourselves and change our attitude for the sake of our country and generations unborn. Let us revive our cultural values, which are our essence as a nation. Let us renew the spirit of patriotism and hope in our dear country. Do not take or give bribe. Be punctual always. No more African time. We can't expect to be global citizens and operate on African time. Join the queue. Insist that people are attended to on a first-come basis, no matter who they are or where they come from.
Nigeria, good people, great nation.
Make you report any crooked person, object or wakajube movement to police and security agent demo.
The security of our nation now work for all of us, plus including me and you.
Nigeria, make we unite against terrorism. Now, Federal Minister of Information and Culture bring on this message.
NTA Tuesday Live, a network issue-oriented innovation talk show.
Well, thanks for staying with us. And the issue is the NHIS scheme. We're trying to see if it's working out to fulfill the reasons why it was set up. And just before the break, we had Namama from Kaduna put forward a suggestion and say, if the healthcare providers are having issues with the HMOs, why not pay them the money direct? He wanted the ES to respond to that. And we've also said, beyond that, why has it been difficult for the NHIS itself as a regulatory body to carry out its functions and sanction airing HMOs? So, yes.
Right. Thank you. Namama, you should be the next ES. So this is my thought. We should pay hospitals directly. And our partners are asking, whatever they bring in to us, they need to be sure that money gets straight to where it needs to be. That is the facilities. Currently as is, I cannot guarantee that given money to HMOs will get to where it needs to be. So Namama, you have my chair anytime you want to. But seriously, Cyril, when I came to this job, I came from academia, seeing patients and doing research, brought into this chair. And I realized the potential of this agency to do a lot of good for our people. I really do. Not only our people, our civilians, but our people in the armed forces, our people in the security services. But that potential has not been harnessed over the last 12 years. Painful. We have that potential to do that. So I look back. Nobody told me what this thing. The fact that we are having a discussion today about NHIS and corruption in the healthcare financing system itself, it's progress. Why? Because I'm shaking the tree and telling everybody there's a problem here starting from my house. And it cannot continue like this. UHC, universal healthcare coverage, will be a pipe dream in my lifetime, in my children's or grandchildren's lifetime, if we continue this way. I said it before and I will say it again. NHIS over the last 12 years has worked very well for HMOs. Has not worked for Nigerians. My mandate is to make the NHIS work for all Nigerians. And that's why I'm here. I'm cleaning my house. First, I'm cleaning my house and telling my folks that, guys, we are here to serve, not be served. We have served HMOs enough. Now is the time to serve our people. Serve our people. Look at, I was carrying files in Ghana Must Go Home, doing sleepless nights, finding all this, issues with HMOs, issues with banks, issues with contractors, issues with consultants. What I see will make any decent human being cry. People's money. And that's what informs my fury each time. We are going to do it right, starting from my house. We're going to clean it, we're going to get rid of corruption in NHIS, and we're going to hold HMOs and hospitals accountable. I've started doing that. There's nothing wrong with our act. The act empowers NHIS to be the regulator it needs to be. We've not been enforcing. That's why when I came, I created a department of enforcement. And all hospitals and HMOs are feeling the pain now. Patients call us directly. They have access to me, they call us. And we write to them, you pay up. Or why are you doing this? We call hospital providers, we call HMOs to account for their deeds or misdeeds. I have an enforcement department that's working. And currently, starting from Abuja, I have deployed desk officers to all major hospitals in Abuja, for them to be advocates for our patients and for them to be our eyes and ears. Because hospitals overcharge patients, hospitals do not treat our patients with respect. They know they have somebody to go to and then report to me directly. And nationwide, no HMO currently has a license to practice. All their HMOs, all their licenses have expired. I am reaccrediting all HMOs nationwide. I have put an ad in 2 newspapers in the north, 2 in the south. The first condition for reaccreditation, for passing reaccreditation, is you must get a certificate of non-indebtedness from all the hospitals you serve in this country. That is the only way to get debt off the table for me to concentrate on hospitals.
Well, yes, that's one condition for those who will be reaccredited.
Yeah.
You know, we hear people say Nigerians can be very cunning. Those who circumvent procedure can be. Now they're looking at the issue and they might not get that accreditation anymore. It's quite possible some might rush to go and offset those debts so they can get those certificates and come back to you. What are you going to do about that? Because these people are also...
All right. Okay. This is one of many conditions. At least we are giving hospitals their money.
Yeah.
And at least we are not paying 3 months in advance. I am reducing my exposure. And I'm going to consolidate HMOs and make them responsible. It's not only that. We'll look at complaints against HMOs. We'll look at your performance. We'll give you targets. And you will achieve that target for me to give you people's money. Fellow Nigerians, NHIS money is not some federal government capital allocation. It is people's money to be used for people and their families when they go to hospitals. What we've been doing over the last 12 years, handing over people's money blindly without asking questions to HMOs.
Right. Some people have raised questions about the numbers. And you think 59 is manageable, or you think you do better with fewer numbers?
I will do better with 0. I'll pay directly to hospitals. If I need, if the act says there must be HMOs, HMOs should not touch this pool that is already. They should go and accrue more patients. And honestly, they should be restricted to their geopolitical zone so they are close to people.
Okay. Just before we come to you, Dr. Walker, let me just put this to Dr. Ogulade Felix. And one or two issues that have been raised. So, well, in a situation where you go to a service provider, go to a hospital, and, doctor has seen you and made a prescription, and then you go off and they say, out of stock, go and buy outside. What does the patient do?
Yeah, thank you. The issue of drug prescription not available, there are one or two things that might happen. That's what we call NHIS list. And not necessarily that the drug is out of stock. But most common problem we have is some drugs are not on NHIS list.
Okay.
And if a physician felt that this drug is very important, so at times they give the prescription to the patient to go and buy. And that is the most common problem, especially the generic drugs. Like as a physician, as a surgeon, you wanted to go and do a surgery, and you have a choice of drug, which might not be on NHIS list. So definitely you run into a problem of making choice of that drug because of your experience and what is on the list. Example is a brand drug, Rusefin. In the market is about 4,500. And you operate on somebody, the scheme says if you use a trial on branded drug, it's about 400 naira. So you as a surgeon will be careful to choose the branded one that you're sure of and the one in the market. So at times, you got the label of, can you afford this drug? Some of them will say no. Some of them will say they want what's on the list. So it's just for the patient to be well informed about what is on ground, what's on ground. But drug not available is not a common problem.
Okay, we took our cameras out to ask citizens their assessment of the scheme so far. So let's take a look at what correspondents came back with.
First instance, NHIS is meant to cater for the welfare and medical treatment of staff. But on getting to the hospital when one is sick, they have categories of drugs they give to people that are for NHIS. They have some doctors, maybe the NYSC, that will attend to the civil servants. Some drugs that is supposed to be administered to one is not given. So why are we contributing? If there are classes of drugs you can give to somebody, and the scheme is not covering everything. If you have an eye problem, they will say it's not covered by NHIS. God forbid bad things. Some people who have cancer, they will tell you it's not covered by NHIS. Why is it so?
Maybe trying to change the hospital you initially enrolled in. Like when you are in a particular hospital, you want to go to another hospital with your families and all the necessary information, they find it very difficult. It becomes a complete, it will take years, sometimes 2, 3, 4 years, you have not gotten the new hospital you intend to go and join. That is the only problem. Even though their services are okay.
They are not implementing to the latter what the policy was meant to be. We contribute to, the health scheme individually as civil servants or as contributors. But unfortunately, when you go to any of the clinics or the hospitals which you have subscribed to, in most cases, the drugs are not there. And ordinarily, they are supposed to get you the drugs. And unfortunately, even when the drugs are not there, the bill is still passed on to government. Because at the end of the day, they still pay them. And there's a collusion between.
So many civil servants can die just because of malaria. But if you go there, test is free, total free. Consultation is free. It's only drug that you pay 10%. Some people are doing operation. They will say 120,000, 200,000. They will pay 10% of it. To me, as far as I'm concerned, I really appreciate government for this facility.
At the end of the day, I see in this NHIS. My suggestion for NHIS is that hospital, we should just deal directly with hospital. They should scrap HMOs, because most of the HMOs are in Lagos.
NHIS, I think the highest I had ever paid was 50 naira. So even though our money are being, the medical allowances is being held, but I think it's better.
Like me personally, about 6,500 naira has been deducted from my salary every month, and I have not gone to the hospital for the past 6 years. So I felt it's a cheating for those of us who does not visit the hospital.
NHIS has been so effective to me. I don't know about other people, because I have 4 kids, and plus my wife, myself, making it 6. We have a slot of 6 people because I subscribe this gold, silver. So which covers 6 people, and it has been effective to me. We've been going there, the hospital I'm using, when they were not managing us very well, I changed to another hospital which is getting terminated. Based on that, despite that it has terminated, they still give me 1 year to go for medical for 1 year. I was terminated this May 31st, so they gave me till May 31st of next year. So to me, I think it's something everybody needs to subscribe.
The citizens speaking there. It would seem that there's still an issue about what is covered under the NHS and what isn't covered, and the question of which are the drugs on the NHIS list and which are... How does a patient cope with all that and knowing what is what?
Thank you. Let me, before I answer that, because I have certain things lined up, let me just quickly mention them, please. Yes, we are talking to the media. We expect you to enforce the law. We are in support of it. I can assure you, all my members, they want those of us doing our work well to be vindicated, so that we know that we're on the right path. So please enforce the law. That's number 1. Then number 2, HMO are big stakeholders. Take us into confidence and meet with us. You have been on this seat. You have never called us to meet us so that you hear from us our own knowledge. We believe that this is 2017. This scheme started in 2005, and we started with 500. Now they are on 750. If it is high time we did another actuarial valuation. This is a scientific valuation by actuarial scientists that will tell us whether that premium that we are paying is adequate or not. Because once you are sure, the provider has been whispering to me that the money they are paying is not enough. And they will still believe that it's the HMO paying them. No. If you think the payment is low, the NHIS cannot even increase unilaterally. It has to be computerized by actuarial scientists. That is what is done. It should do it as quickly as possible and know whether the premium is available.
Okay, so you're thinking it is possible that the premium is too low for what
them.
cover has been provided?
Good. That is it.
We'll come to that.
And then, as we were saying, please, this scheme, the ES has repeated twice. If we had this way, it will pay low. Look, we are laying down structure. In quality, you want a good structure, a good process to give a good result. We are not saying something that will stop tomorrow. We want something that will last forever. And that is why the HMO was put there as a control. If he pays directly to the hospital, who monitors him? And if he believes that he is honest to do that, what about the man that takes over from him later? So there must be somebody to monitor and be in the center. And that is why the scheme was done. The stakeholders that sat down on these things, they are more than 50. And they worked tirelessly. We've been on this thing since 1991. Start quoting 1999 is it's not starting points. We'll be on this thing with all the stakeholders, several doctors, several meetings. The documents are there. I'm sure you can get it. So it's not something. So this PP was put there to make sure that there's a control. Somebody will be at the back to profile both the HMO and the healthcare providers. So you can know those that are doing their work. And then you can make sure that the scheme has its control. And then not only that, please, this scheme, we have said it over and over. Some providers we have 2, some we have 5 enrollees, some we have 20. No, all over the world, what they do is make sure that providers get like minimum of 2,000 enrollees. Because by the time you give a provider 2,000, multiply by 50, that's 1.5 million. There's no provider that gets 1.5 million every month that will not treat those enrollees as if they are eggs and cater for them.
All right, the issue of what is covered and what isn't is still pending, but we have to take this call from Kaduna now. Mohammed calling in from Kaduna. Hello.
Hello, good evening, sir.
Good evening.
Yes, my appreciation to the ES on his contribution on improving the NHIS platform in Nigeria. My contribution now is this. I think I support that the HMOs should be scrapped so that the NHIS will deal directly with the hospital so that we will get a better service.
No, honestly.
That's my contribution.
All right, thank you very much, Mohammed. So let's return to what is covered and what isn't covered. A patient gets sick, a person gets sick. All they want to do is get medical attention. And no one's going to go around and say, look, do I know what is on this list? I mean, so where do we get to clear up the issue of what is available on what's on the NHIS list, what drug is on the list, or, for instance, what ailment is covered?
I think it's education we need to give a lot to everybody. In the developed world, they will tell you that if you get to a place, the health plan you buy, something is not covered, then what you can do is they ask you to pay a particular amount for whatever you want to do if it is not covered. But here, we just started the NHIS plan, and we are giving them the NHIS plan. And that NHIS plan was because the government started with the 10% the government wanted to pay. The Labour were not ready to pay their 5% at that time. And even up to now, it's not everybody that is paying that 5%. So we said that, okay, this benefit package was done by actuarial scientists. It's not anybody. It's not somebody who wake up and just wrote them down that you get this, get. No. It was scientifically it was done by the actuarial scientists. So what we need to do is go back and see what the actuarial scientists can bring out now, the actuarial, to see the premium and to see if you increase the benefit package, what will be the new premium and what will be the payment ratios.
We'll come to the ES on that matter of what's covered. But let's get this call in from Rivers. Prince calling in from Rivers. Hello, Prince.
Yeah, I want to say that. I want to say that I appreciate the service. I witnessed one somewhere in city of Port Harcourt. But I actually stay in the rural area. In this rural area, most of us are not civil servants, workers, neither in the federal civil servants. So, and like I heard from Dr. Wally, there was a comment he made that this service was supposed to be universal. And most of us in the rural areas, we don't have any, most of us are not into any of the civil servants services. And what we try to do as to participate in the NHIS is to use our community project fund. We use our community fund project to finance, to fund this NHIS in the rural areas. And most of the time, we don't have enough people to actually participate and to as in to pay for their premium to enable them participate. So what are they really doing to accommodate people in the rural areas that doesn't have relatives as to actually participate in the benefits?
All right. Thank you, Prince. Thank you for calling in. So let's come to the Executive Secretary. Still, there's a little matter of what is covered, what isn't covered, and question of perhaps if there was a little more money, the premium may be low. We don't know that. That service would be better if the premium is raised. And of course, we still have the issue of the expansion of the scheme. The last caller just talked about communities, those outside the federal civil service structure. What are the states up to, and how are other people, the organized labor people who are out there, can get to benefit? And of course, we do know that quite recently, youth corps members, it's been approved for them to get under the scheme as well. So there's a lot on ground, Executive Secretary. Let's begin with what is covered, what isn't covered.
Perfect.
Right.
So let's look at our package is very robust. If any healthcare facility tells you this is not covered, this is not covered, a lot of the times they are being economical with the truth. The last segment where people say they go through cesarean sections and operations and they end up paying 15 naira, that is closer to the truth than any. Let's go back to drugs. There are drugs we call generic and there are drugs we call branded. If I go to a pharmacy in Abuja, I'm a physician, go to buy medicine for my daughter. Ampicillin, give me ampicillin. Oh, this costs 10,000, 1,000. I say, no, I don't want the 1,000. Give me the 201. Generic. Works just as well. I'm a doctor. I know. So there is this thing about branded in Nigeria and generic. Generic is just as good. It is the responsibility of healthcare providers, hospitals, to educate patients that generic medications are just as good as the so-called branded. I've been practicing medicine for 35 years. In the United States, branded medications stay there for 10 years after that generic medications are manufactured. Right. So generic medications are just as good. It is the responsibility of HMOs, it is the responsibility of healthcare providers and NHIS to educate our people. I go to pharmacy, I buy generic drugs. Our packages are very robust. That's why we are deploying desk officers to counter when hospitals say this is not covered, this is not covered. It is not true. What was the other question? Okay, we talked about let's review this, let's review this. Nigerians need to notice and hear it clearly. HMOs, all they've been talking about is the money. I'm talking about people, patients. We've done this for 12 years. How many more years do we need to say we've not done it right? 12 more years? We have not done it right. Let's admit. I have admitted, doctors have admitted, HMOs are still in denial. We have not admitted it hasn't worked for all Nigerians, and that's my mandate. We'll make it work for all Nigerians. My goal is to increase coverage outside the formal sector, go to our people. All of us, if we get out of the comfort of Abuja, we go back home to our ancestral home, who have we left? The people we call the vulnerable, mostly the aged, widows, widowers, women, children, the disabled, the unemployed, the urban or rural poor. These are my target. They are over 95% of our people. These are the ones I want to, the market is there. During the last month, I was in Kaduna, I went into 4 large mosques. I went into 2 large churches, sensitizing people and telling them what NHIS can do for them. And the churches, the imams and the pastors said, somebody is coming to tell you what government is doing, what government can do for you. That is our job as advocates for NHIS. HMOs should do the same, doctors should do the same. I am way ahead of them, and I'll be the regulator I need to be.
All right. So now we're going to push the scheme to get the informal sector down to the rural areas. Where do the states come in here?
Good. So in Nigeria, they say health is on the concurrent list. My big boss, my elected representative will tell you that. We cannot, the federal government cannot dictate to states what they do. So what we have done as the NHIS, as the regulator, we have over the years been working with the state governments, especially the governors, Ministry of Health, and local governments, to help them create their own state health insurance scheme. We as technical partners, so that we see, and in discussion with governors, but this is the reality. The reality is, even if you create the scheme in the states, how do you fund this pool? How do you fund it? Because in the states, we all know there are difficulties even in paying salaries. And taking money off of workers will require an act of Congress. We are NHIS. We are looking at creative ways of funding this pool. And I'm very happy. One of the things that is coming our ways is the Basic Healthcare Provision Fund. The National Health Act of 2014 said 1% of the consolidated revenue will be dedicated to health. It has not been populated into the budget yet. But our development partners are eager to fund the pool, even before our government does that, because they, as us, see the potential in this fund making a difference in the sobering health statistics in Nigeria. 50% comes to the NHIS, 45% primary health care, 5% to the Federal Ministry of Health. Where I am hoping to deploy the 50% that comes our way is for us to cover our vulnerable. These people I mentioned, they are our people. They cannot afford to pay. This is the reality. And they're over 80–90% of our people. They are not formally employed, but we can help them. Another program, NHIS, is, that's why I'm advocating all over this country. There's a program we have. When I came, there are tons of programs. None of them was working. If they were working, we'll be having millions of Nigerians. I say, guys, let us concentrate on one ship we can all get on board and see how it works. The ship I see promise in is called VC ship, Vital Contributor Social Health Insurance Program. Cyril, I will highly recommend it to you as a retiree. For 15,000 naira, Cyril. For 15,000 naira annually, which if you break it down daily, it's only 41 naira every day for 365 days. You will enjoy the same health access as I, the chief executive of this agency, would enjoy. We are going to generate that number. And that is the same thing we sold when Mr. President was informed there was a loss of a copper. And he was very disturbed, asked the Minister of Health to write a memo to present to FEC that was recently approved. It is this, the federal government pays this amount for each copper every year. we are going to generate a large number. And Cyril, you, I, and all of us on this table, we can pay for many more. Our scriptures and our cultures say, the strong pays for the weak, the healthy pays for the sick, and he who has pays for those who do not have. I'm pricking the conscience of our people to fund into this pool so that we can cover our people. Government is done very well. I'm one of those critics of government before I came into government. But I have seen in the NHIS what government is doing is because government is funding this pool, that is why people can pay 15,000 and enjoy the same health care as I can. But we have to do for ourselves. I'm looking at creative ways. VC-ship is one of those. What we get from VC-ship, we'll be able to go and cover our urban and rural poor. And we are reaching out to our development partners. 15,000 naira is just $33 a year. We have 170 million Nigerians not covered. That is a lot of money, and we can cover our people. That is the way I want to reach our informal sector. Formal sector is mature. All I'm asking, HMOs, get off this gravy train and go into the informal sector. Leave these let's pay hospitals. Go tell me, and I will give them. I will give them target. HMO A, B, or C, how many have you brought in this month or this quarter? Because what we have been doing, Cyril, is what I will tell them is go and eat what you kill. What we've been doing to them for the last 12 years, we kill, we roast, we feed them, we give them water.
All right. So let's turn to the lawmaker.
Yeah.
In all of this, you've held a series of meetings, you've consulted with the people as a representative of the people. What's the way?
We have finished the first leg of our investigation, and we are going into the second, and we've even commenced. And this level, what we're trying to do is forensic analysis of all the data received. Like I mentioned, we've received a lot of submissions from various stakeholders, including the NHIS. So we need to go to the field. We want to visit the HMOs, the service providers, to further ascertain, verify, the claims and counterclaims, made. And along the line, along the way, when we get this done, we will now come back and further analyze, discuss, and see, what is the best way, forward, really. A lot of suggestions, have been made, including doing away with the HMOs, direct payment to the service providers, as well as trying to register HMOs on the basis of geopolitical zone, because part of the difficulty has been that the HMOs are concentrated in maybe one part, or one state, in the country, and that makes it very difficult for them, to cover the whole country. Yeah, the HMOs are many, they're 57, but then they are concentrated, living sincerely, within one part of the country. For instance, I remember in one of the examples during the public hearing, which the met was that it would be difficult for an HMO from Lagos to cover, people, in Borno State, Adamawa, or as far as, Sokoto. So you need to have, more of this, within the area of their reach, So, but like I said, we've not concluded, yet on what to do. Certainly, some of the things we'll do will definitely have effect on even, the law, itself, because if you say we were going to do away with the HMOs, you will have to review, the law. It's not something which I can or somebody can wake up and say, look, you do that. We have to go through, the processes. So we'll come back and discuss and consult before we take our report, back to the House, because remember, like I mentioned, the House, gave us an assignment. So when we conclude a thorough job, then we'll take our findings, to the House, where the larger body will really discuss, the findings. And at the end of the day, whatever recommendations are made, it will be recommendations that will really enhance, the health status of all Nigerians.
Let me bring in Dr. Walker here, and to respond to what has been raised about HMOs staying in the geopolitical zones. And since you've represented the HMOs, do you see this as a really workable procedure where you have, for instance, a HMO in Lagos and someone who's a patient right there in Garkida or in Shatta or somewhere in Kateregi, and they go to hospital and they have to start calling someone in Lagos to take care of that?
I think it's still part of the misinformation outside. We have branches. At least I know HMOs that have more than 32 branches. And I know those who have 36 branches. And I know those who have branch in every state. So it's not, they should check the books again. They will discover that there are HMOs who have branches in every state. Then apart from that, everything we do has been programmed into a book that we follow. What you are being told is that when you have 5,000 lives, it's a must to have a branch there. And we have followed that faithfully. So once you have 5,000 lives in a state, you must have a branch there. So it's in the NHIS operational guidelines that we follow. So it's not that arbitrarily we stay in one corner. It's not. And I believe, I want the Honorable to please go through the books again, and you see so many HMOs with so many branches. I can assure you of that, because I can quote more than 20 offered that have more than 20 branches. So it's not. And then let me add, please. We are talking of community-based. Community-based worldwide has three fundamental things that if you don't follow them, nothing will happen. One, there must be spirit of self-reliance in that community they are taking up. Two, it must be a prepayment scheme with a pool. And then three, there must be community participation, full participation, and eventual ownership. If you don't put these three things in place, you cannot enter the informal sector. And we have been waiting. That is why we said the ES alone cannot go along as it's going along. It has to. The HMOs are a big stakeholder. And as of today, we are sitting down and talking. If you don't call them, sit down and let them know what you are doing, and we match it with what we have in mind, you are against the law. You are not following the law. As long as that is the law that exists. And if you want us to move to the informal sector, let's sit down and discuss. We have never really sat down and discussed. It's been here since 10 months. He just called us one day and dressed down everybody, and we left. That's all. So I don't know how he believes he alone can go ahead doing all this and get to universal health coverage. We don't understand. We are just looking.
Where does it come in? Talking about the licensing of the HMOs.
Yeah, why not? He's the regulator. He gives licenses.
So
yeah, we have seen. We have seen the.
At what point did we get to where it was alleged that so many of them were operating, their licenses had expired?
No. It's a cyclical thing. It has ended, and then he has to put him. He has to do what he has done. Put in an advert and tells us what he wants, and everybody obeys.
I'm asking this because I'd just like to know how the procedure, what's period.
There are some HMOs who even wrote, because I remember they said it. They wrote when it was getting to December, that by December the certificates will lapse.
So
and
what happens what are in between? That's what I'm more concerned about. Now, what happens in between?
We have started doing the needful. We've started doing what you put in the paper, and we are set anytime. We are chief executives in our own right, so we know what we are doing. So we are waiting. It's to give the flag. Once he gives the flag, we know what to do. But what we are just saying is he needs to interact with the stakeholders to really everybody wants, we are Nigerians, and we have gained from this country, and there's no reason why we will not put back. When we started the scheme said they will pay HMO 15%. We said no, 10% as worldwide. We don't want anybody to come and start checking your books and see that if the whole world is getting 10, why are you getting 15? Any payment made is actually calculated, and it is internationally denominated. So it's not a question of anybody saying somebody is paying, is being paid any money at the backyard. So we want that so that we know how we are moving.
Okay, let's come. Yes.
Right. Sorry. It's part of the mess I met here in the NHIS. The reality, and this is not new.
Yes.
The reality is HMOs have been increasing the number of enrollees based on which we pay. This has been proven.
Now,
remove them now.
Is there a specific number? Maybe I should raise this. Is there a specific number that should be, they were saying, for instance, is that part of the act, also saying there must be XYZ number? Yes, the law says there would be HMOs.
No, there's no number. Israel has 4 with 8 million population. Okay. Switzerland has 60
so
with 8 million population. There's no number. Plus. It's just for the regulator to do their job in the correct way.
So the question is, for me, I'm result oriented. We had 57. What have we gotten over the last 12 years?
Can we get better services with fewer numbers?
With zero.
You cannot get with zero.
No, we can't.
Because
I'll tell you why.
You will be a lord unto yourself.
I will tell you.
And it will be wrong. Who will monitor you? Who is going to monitor you?
Let me tell you. We have the House, we have the ministry, we have a board.
No.
Let me finish.
We know what happened tonight.
The reality
is,
we
know what happened to Nigeria Airways.
But over the last 12 years,
what about our pension? Look at our pensions. For instance, is it not the pension reform that turned it?
Okay.
They were being done by them alone.
PP, public. Usman has
it
said.
It should be public-private partnership.
As Honorable Usman has said,
put in? Zero.
It's a question of what the Act says.
Yeah.
So now the Act makes provision for HMOs.
Good.
Leaving them out would require an amendment which has not been done. So if we look at the current situation that the HMOs are there, is there a way that these numbers can be brought to a more effective and manageable
why not?
level? Can the NHIS do that?
Absolutely.
Why not?
So the Act, there's nowhere in the Act where it says take people's money and give HMOs. Nowhere. I have read the Act, I've asked my lawyers to look into that. There is nowhere in the Act where it says pay them 3 months ahead.
Okay.
There is nowhere in the Act where it says pay them fee for service, 25% of fee for service is used. They are supposed to return 75% of that. They're silent on that. The Act says
we are now using more than 100%.
HMOs will be involved, but they need to go and accrue their patient. What have they added in terms of number for us to achieve UHC? Okay. How many have they brought in? They are just eating where they have not sown.
So since we're all looking at how to expand and make the scheme better, just before Dr. Felix, how can the HMOs work to expand the scheme? We've heard talk about bringing in more. What are they doing towards that?
What are they doing?
A lot. We have our private. The HMO started working with private even before NHIS started in 2005. We had all our private clients. Even as of today, corporations are not under NHIS. They come to us directly.
Right.
And we pay 1% of whatever we collect to NHIS. What we are saying now is, which is done all over the world, let us make it compulsory. Because, okay, let's take general insurance. General insurance has been before I was born. What is the percentage coverage? 10%. That's general insurance. Nigerians generally don't believe. How many, look at those people, they just have third-party insurance for their cars. That's all.
But so would you not say that's because it's never really worked, and that is what has been extended to the NHIS?
Good.
People don't trust insurance schemes.
Good. That's what extended the risk. So that's what we are saying. So we do our own private, and we are on it. And we are ready to move faster to community and other things. And that's why we have been saying, let us sit down with our regulator and see how we can move ahead. Because this individuality of just going with the VC ship means that moral hazard, adverse selection, everything will come in. Because we don't like, insurance is pooling. The bigger the pool, the better for everybody. If you start going after them one by one, it's only those who are sick that will come first. And therefore, it will defeat the pool. The pool is not bottomless. It can dry up, and then market forces come in, and you discover that you have zero money.
All right, Dr. Felix, way ahead, moving ahead.
Yes.
Expanding the scheme, and, well, from the point of the health providers, who would say that, well, they've got to think, well, where professionalism stops and where profit motive comes in.
Yes. Thank you, moderator. The scheme is quite laudable, I would say. And as the HMO chief have mentioned, at the healthcare provider level, one of our problems is the enrollee number that given to each. If we have distribution according to your environment, like you are in Maitama, I'm in a hospital in Maitama, there should be a guide that makes sure that patients choose those registered hospitals by NHIS Maitama.
That was on. I recall that when the scheme started, we did programs on it, and the very first complaint was that hospitals were complaining that, no, we can't take, there are too many, we don't want people there. So people were forced to leave, you know, the areas where they were to go and go to, you know,
which is not.
But it was real. We did a topic on that on this same program. I recall that.
That one was very glaring in National Hospital. But the problem is, see, there are those people that enter the scheme early are still having larger enrollees that they cannot manage. Whereas some hospitals are just having like 2 patients from HMO. So if there is a way that there will be equal distribution of patients or enrollee according to where they are living, and they can have about 5 choices around that area, then there will be base where you can pull from. Like you rightly mentioned, if you have a 2,000 enrollee in your unit, you have a lot of work in your hand. So you will be working seriously to make sure you maintain them instead of begging for people to come. That's one. Then 2, the main problem again is the issue of drug. I went to big pharmacy, like Prof. rightly said. There's problem with generic name and branded name. I think in a country like UK, there's what they call Teva products. That yes, the government actually went into packaging of that drug and subsidized it, and there's equal distribution. Even some of them come to this part of the world for maybe rural distribution of drugs. If NHIS can get a big pool to encourage a pharmaceutical company to pack the drug and label it NHS, so it will cut off the problem of drug is not available, drug is not on the list, and you know that is paracetamol, there's NHS paracetamol, and it's got quality. All the other player, the pharmacists, the physiotherapists, the optician, all of them, we know that yes, they are in the scheme. Then our homework is to provide the scheme, but everything we need should be readily available.
All right, as we wind down and round off this program, at the center of this all, it still remains that it is the people who matter here, the person who needs this cover. So we'll go back to the people's representative and say, in your closing comments, what can we do to get this to the people who really are the center of it all?
Well, let me say that we must really move from where we are, you see, today. The fact that as it is today, only 1.5% of the population is really covered is really unacceptable. We must really work, seriously towards larger coverage. I don't want to really preempt what the committee is really going to come up with, and that's why I'm very careful. But we have collected a lot of suggestions, a lot of recommendations from all the critical stakeholders, and I want to assure Nigerians that whatever we're going to come up with within the shortest possible time will be something that will help in Nigeria attaining universal health coverage. We are in a situation today really whereby the HMOs, as we are today, are operating illegally because their licenses are really already expired.
Okay.
And us get out of the situation that we are.
So probably we'll just ask the executive secretary how soon can we get these licenses regularized and get the scheme on, and just hopefully enrollees will not suffer as a result of this. That's the important aspect of it.
Right. So my goal and vision for the NHIS is clean my house.
Okay.
Reposition the NHIS. Serve and not be served. No deals under the table like it's been happening before. Hold us accountable, the NHIS as a regulator, be the regulator we need to be. We take over enrollment, we make sure we account for the money, we make sure patients get referred properly, and we make sure we are better regulators. Hold HMOs accountable. Every penny that's given to you must be paid where it needs to be. Hospitals, hold them accountable by putting desk officers, by treating our patients with the respect and dignity they deserve. Many hospitals get millions of naira every month as capitation.
Okay, just one thing, the registration, you recertify accreditation. Yeah. As it's going on, it's not going to affect the enrollees in the scheme, will it?
No. I mean, that's why.
Okay. So there's no lacuna.
No, we have to regularize and make them legal, and we will do it in the right way. Those that do not qualify will not be HMOs.
Okay, so. And it is on that note we must leave this discussion. There's still a lot to be talked about it, but hopefully at some other point in time, we will ask our guests to come back because they still have a lot to do, especially the executive secretary. We'll ask you to come back some other time and see just how much progress we have made. But for now, we have to leave it here, and we'll say thank you very much to Honorable Mohammed Usman, Deputy Chairman, House of Representatives, Committee on Healthcare Services. So thank you for being here. We also say thank you to Professor Usman Yusuf, Executive Secretary, National Health Insurance Scheme, the NHIS. Thank you for sharing.
Thank you for having me here today.
And Dr. Kolawole Owoka, Immediate Chairman of the Health and Managed Care Association of Nigeria, the umbrella for the HMOs. Thank you for being here.
Thank you for having me.
And thank you also to Dr. Gunade Felix, a former executive member of the Nigerian Medical Association, FCT.
Thank you very much.
Thank you. And it's thank you to you too for being part of this program. Next week we'll reach you again on NTA Tuesday Live. I'm Cyril Stober. Bye for now.
The hands of an artist never seem to lie.
Our programs are getting better and fresher. And it's because we are thinking about you. NTA, it's all about you.
This is the network service of the NTA.
Bauchi State occupies a total land area of 49,119 kilometers squared, representing about 5.3% of Nigeria's total land mass. It is located between latitude 9.3 degrees and 12.3 degrees north and longitude 8.5 degrees and 11 degrees east. The state is bordered by 7 states: Kano and Jigawa to the north, Taraba and Plateau to the south, Gombe and Yobe to the east, and Kaduna State to the west. Bauchi State is unarguably one of the states in northern Nigeria that spans 2 distinctive vegetation zones, namely